Over to you, Dr. Shroff.
Thank you, Pallavi. So did we have the poll done? Can I just quickly have a review of the results?
Sure. Ganesh?
So I just put up 3 or 4 questions, simple questions. As per our law, transplantation, the latest one, who signs the consent for adult disease donation? And we got a response form 4, 6, 8, 10. And 8 of you said form 8. Some said form 10 and 4 and 6. That means there is still not clarity. Which form should we use? It is form 8. Form 8 is the right answer.
That's right.
And then again, the same question was for pediatric disease donor. Some more confusion. Again, it's form 8. The form is the same for both. And then which form should we use for declaration of brain death? Only 14 people answered, or 15 people answered this. And everybody didn't answer. I'm not sure why. But again, this is form 10, not form 4, not form 6 or form 8. So remember, it's form 10. Those of you who got it wrong, don't get this aspect wrong. This is the basics for disease donation program. So thank you for my introduction. And, I'll get started. No financial disclosures. The graphics I've used on these slides are either from MedIndia, Mohan Foundation, or Wikipedia. So Pallavi and Natko has asked me to talk about retrieval of abdominal organs in disease donor and the bench surgery and transport. And then Dr. Arvind will talk about. To start right from beginning, organ donation after brain death, 1 donor, 8 solid organs at least, and up to 50 tissues. So multiple lives are saved or enhanced. After brain death, almost the whole body can be recycled, organs and tissues. I'm not going to go into details. You guys are expected to know this. So let's start off with, kidney transplant surgery, what's happening in India. Just to inform you that India has the largest experience with living kidney and living liver transplant program. As far as the numbers are concerned in the world, we do the highest numbers today. We do about close to 12,000 kidney transplants. I think it's not, sorry, 11,000 kidney transplants and about 3,000 to 4,000 liver transplants, living liver transplants. But we do less number, about 10 to 15% of these are from disease donors. We are among the top 10 countries even in disease donation as far as numbers are concerned. Last year we did about 1,068 disease donors. So we are in the top, but if you look at per million population, we are low down, very low down. Technically, the skills of Indian surgeons has been extremely good. We do a lot of lap and minimally invasive surgery to remove the kidneys and now even the liver. And we have a huge experience with this as well. So, when you're in the operating room, I have this, mantra. I used to call it the cadaver drill. At that time, disease donors used to be known as cadavers. So I used to train my residents and my, medical staff and coordinators that before you proceed in an operating room, as surgical team, as you're in charge, you have to do essential checks. Just like when a plane takes off, a lot of essential checks are done before a flight takes off. Same way, this is absolutely a must in any program. Without that, you don't start. And the first thing to look at is the consent form from the donor. Form number 8, who has signed it? Check which organs the consent has been given for. Check form number 10 for brain death certificate. Check hepatitis and HIV virology status. Check blood group. Check last few hours of hemodynamic status. So these checks are very, very important. Without that, you don't proceed. If you do this, a lot of errors will be avoided. So other checks, if it is a medical legal case, check if forensic team informed about postmortem. After the retrieval postmortem has to take place. So if forensic team doesn't know, there'll be delays. Ensure that there's no commercial dealing. Just make some inquiry. And also ask the coordinator for history such as dog bite, drug abuse, if possible, sexual orientation, if possible, history of tuberculosis. These are all important in the long term. So you must make inquire into these. You had situations where at last moment we found out that there was a dog biting the donor and we had to abandon the whole thing. This is form number 10, which is a brain death certificate form. It should be signed by 4 doctors, as you know. Neurologist, person in charge of the hospital, RMP, nominated by the panel, RMP looking after the patient, neurologist, neurosurgeon, ICU person, 4 people signing this form. Very important. Consent form 8, signed by the relatives. So after you've done all the checks, patient is ready on the table. What happens? If there is I'm not going to go into getting great detail on surgical aspects because I would try and show you whatever I think is required. And we'll talk more on, the logistics. Choice of incision, if both thoracic and abdominal organs are taken, then the choice of incision will be this incision, which is a long incision starting from here top and going down right down to the pubis. So this is suprasternal notch is called, and this is xiphisternum. So it starts from suprasternal notch here and goes right down to the pubis. Huge long incision. If only you're taking abdominal organs, if the patient lean and thin, now normally we'll give again an incision, which will be something like this. Starts from xiphisternum, goes down to pubis. If it is a patient who is a little bit on the fatty side, obese side, and then you may do what is called a cruciate incision, crisscross. So these are incisions just for your knowledge, not so much that you need to.
Thank you.
Somebody's.
It's a nice thing that you have. Anything for me, anything like you.
Somebody is. Who is this? Arvind, is it Arvind? Okay. There are 10 key steps
Dr.
in
Arvind was saying
retrieval. Sorry?
Dr. Arvind was saying something?
I think he was maybe not muted or so.
Okay.
So there are 10 key steps in abdominal organ retrieval. What we do is there is something called two vessels, big vessels called aorta and the inferior vena cava. One takes the blood from the heart to the different tissues and cells, supplies oxygen and glucose, and one brings back the blood back to the heart. That is the inferior vena cava or superior vena cava. So in the abdomen, you need to catch this aorta, so and the IVC, you need to, kind of make sure that you are able to see it at the level above the kidney or liver and at the level below the kidney and liver. And in between that, you need to use these vessels, mobilize them so that you can perfuse the organs inside the abdomen by using cold solution, which will be able to, preserve the organs. So the first step is to mobilize and control it above the, kidney and liver, which is called suprarenal region, and then control it below, it's called infrarenal region. And after that, you will put a small cannula to perfuse the organs. And after that, the removal of organs will start. And then you do the bench, work on the bench or what's called back table. And again, you perfuse the organs. Then you may need to remove the spleen and lymph nodes for cross match and all that. And then they'll do a closure of the abdomen. And then you pack the organs and document and transport. So these are the 10 steps in abdominal organ retrieval. Similar steps will be followed in thoracic organs also. That one thing which you often hear is called warm ischemia and cold ischemia. Very simply, if you want to remember what is warm ischemia, when the organs are not in ice, after the circulation stops, till the circulation is running into the organ, till the blood supply is going into the organ, oxygen, glucose will be there. But once it stops, no oxygen, glucose. So when not in ice is warm ischemia. When an organ is in ice, it's called cold ischemia. Normally in kidneys, we say 1 minute of warm ischemia is equivalent to 1 hour of cold ischemia. Sorry about this thing here. So warm ischemia in terms of, describes ischemia of cells and tissues under normal body temperature. And in transplant setting, this term is used to describe two physiologically distinct periods of ischemia. One is during implantation, that is when you are removal of the organ from ice and you start reperfusion of the organs. That is when you are actually taking the organ from the ice and starting your, and till the time you release the blood again into the organ is called ischemia during implantation, and one there is an ischemia during organ retrieval. That is from the time you clamp the vessels till the time you take out the organs. So that's called ischemia during organ retrieval. Just to remember, these terms are important for you. Someday you'll keep coming across these terms. The order of removal of organs, the first organ to remove is heart and lungs, and the last organ to remove is kidneys. In between, you have liver, pancreas, and intestine. And you can either, retrieve them together because they share the same blood supply, and then separate them on the table, or remove liver, followed by pancreas and intestine separately. Spleen and lymph node is towards the end. Corneas, skin and bone and cartilage again can be done towards the end of the whole. All these solid organs are retrieved. So as I said, that the first organ is heart, last organ is kidney. In between are all the three organs, and since they share the same blood supply, you can remove them together. This intestine, pancreas, and liver. So the time factor for organ donation after brain death and transplantation, this is just a cartoon which we use for the general public. Lungs is 6 hours, heart is 4 to 6 hours, liver is 12 hours, pancreas 24, kidneys is 48 hours. You can't store organs, you can only store tissues, remember that. Sometimes when you are doing, retrieval, you can have some surprises on the table. So you have to inspect the organs after you open the abdomen, look at, you can get what is called infection in the peritoneum called peritonitis. The liver may be very fatty. There may be some cancer. There may be some anomalies. This I'll skip. So there was a situation where there is a deceased donor being wheeled into operation theater, and the surgical team realizes that there is no sterile ice for packing. So how do you arrange for ice suddenly? The patient is already being wheeled into the theater. So answer to that is, take 10, 15 bags of normal saline, 1 liter packs, go to blood bank, there will be a -20 refrigerator. In 30 minutes, you'll get all the ice among these packs. That's one way of getting ice. These are all practical situations which I thought will be interesting for you people to know. How do you take out the organs? You have to expose the retroperitoneum. These are, this is the abdominal kind of cavity opened up, and you see this is liver, this is stomach, this is gallbladder, this is intestine. And this, thin lines are the lines where you go around to show what is called the retroperitoneum. So there's organs in front, and the kidney is at the back. And the vessels, the aorta and the IVC, which I'll show you in the next slide, is also at the back after you remove these organs from the front. So you have to get control of those vessels. So that's why you need to do a dissection to go behind into the peritoneum, called the retroperitoneum. So you start the incision from here, go down like this, go around the appendix, go around the colon, right colon, come down like this, and then make another incision on the left side. And this is how you expose the retroperitoneum. And these red lines show you the incisions around the peritoneum. So this is what I was telling you. This is where the retroperitoneal vessels are. This is your aorta, and this is your inferior vena cava. And this, you see the blood supply to the kidney here. And there's the diaphragm, which separates the chest and the abdominal organs. And there are, before when the vessels enter the abdomen, there are these, ligaments called the crust of the diaphragm. This needs to be divided if you want to control this aorta here. And this sometimes is a difficult step. And to make things a little bit more complicated, the esophagus, which goes and gets attached to the stomach, is right in front of the aorta. So you have to go behind the esophagus to get this area. So that's why it becomes a little difficult to find this area, especially if the patient is a little obese. And so you need to control the aorta, and you need to mobilize this structure called esophagus, then cut this ligament, and then you need to control this aorta here. And the next step I told you, if you remember 10 steps, is to cannulate the vessels. And these are the two vessels in the retroperitoneum. The kidneys are here. This is the aorta and this is the IVC. And these are the tubes which you need to put inside. And you need to ligate it so that you can perfuse these organs. You put a tie here on the top, you put a tie down here. so that this area of the vessels gets perfused. This is a brief video. Let me see. I won't play it fully, but I'll play a little bit of it. This is an old video. Sorry. Hoping to control it somehow. I want to move it faster. We don't have all the time.
Bring your cursor on the screen. I think that line will come somewhere. No, not
I
coming.
don't know whether it'll come. All right.
And instead of full screen mode, if you go in a edit mode, then you'll get that line.
Okay.
If
Anyway,
you just press escape, you'll get that line.
I was trying to do that one day.
See now?
No, this is what happens is edit mode. It won't come.
No, you're not
Sometimes-
getting that line now also.
No, I'm not getting, but it's okay. I'll
Okay.
do is I can play it. I can share it again 1 second. I'll share it from my. Give me a second. There's always a way to get around to this problems, obviously. So we'll play it like this, yeah. From the screen. So this is the incision.
You've not stopped your presentation
Oh,
screen
share.
sharing. Yeah.
Incision
Wait a minute.
starting from the
Fine,
sternum
fine.
notch to the pubis is made. The sternum is divided. And the thoracic.
1 second. Sorry about this.
Not an issue.
Can you see my screen now?
Yeah, but not the screen that we need to see, just a lot of videos.
Yeah, video. Can you see this video?
No, not the particular one.
The sternum is
No?
divided
No, Dr. Shroff.
and the thoracic organs are exposed.
1 second.
I think you have to keep it open and playing.
It's open.
Now?
Yeah, yeah.
So let's go back. So this is the incision. And now you see the abdomen organs. You know, I also try to use cartoons to show you.
Made.
And if you open the chest, which Dr. Arvind will show you,
And the thoracic organs are exposed.
cut the chest with a saw. Literally cut with a saw like that. Very gross. And then you see this liver, and you see this heart, it's opening the. This is Dr. Arvind's territory, and more into it.
And the viscera are rotated medially to allow for exposure.
So this will be exposed.
The lateral attack.
I'm sure you guys have seen some of this, yourselves. I don't want to go into great detail, but towards the. Let me see what I need to show you. And then since I'm a kidney surgeon, I'm just showing you. You remove it and then you take it to the bench. Let me go back to my presentation. Which means starting all over again, probably. And if you need, you can also, sometimes when you move the spleen and lymph nodes, as I said, you need, right in the beginning, that helps the cross match when the samples are not there. Another
Yeah,
thing.
somebody's asked this question, why do we take lymph nodes?
Yes, we can answer that as we go forward in the discussion. Because I don't want to overrun my time since Dr. Arvind has to follow me. The next step which we do is take the organs on the bench, which means put it in the ice and you sit down after the organs have been removed and you do the dissection. This you should be able to see where you perfuse the organs more and you remove all the fat, you prepare the organ so that
Your
you can
presentation is
transplant
not
it.
on, Dr. Shroff.
No?
No,
Oh,
yeah.
shit. Surprising. Can you see it?
Yes, it's on the video. Yeah.
Yeah, can you see that? Yeah?
Yes, sir.
Yeah, so you see this, these are arteries being prepared, you know, you have to be very careful that you don't damage them. And this, so that you make it ready, so that you can, use these, and, enough length is there so that you can anastomose this into the recipient vessels quite easily. And this is called bench dissection. The next comes packing of organs. For packing, we either use a container or we use, thick plastic bags, to pack the organs. And the key to remember in the packing is that the core solution, the ice should not be around the organ. When you put the organ inside a bag, this is a plastic bag I've used. You take the ice and finish the first, packing, you only have solution, no ice. And after you tie this, you double pack it into another plastic bag, which has a lot of ice. So that's the key to remember, not to put ice around the organ. And then you can use these heavy bags, duty bags, with which are, with thermocol, which will preserve the temperature. And in this bag, you put a lot of ice around this plastic, which you packed, and then mark left side, right side, liver, whatever the organ is. So this is what you should know about the actual pre-op procedure. I mean, before you take the organ and when you take the organ from in the theater, these are things you should know. And of course, as you know, in the inter-hospital coordination, the donor hospital has to inform the state registry, and then they inform the recipient hospitals. And for kidneys, anything from 1 to 3 patients can be called. So it is for liver, heart, and lung. So a lot of coordination can take place, and then it can take 1 or 2 days for the whole exercise to get over, and it can take almost 60 to 100 hours of work. And when you are doing inter-hospital coordination, first intimation of possible organ that is available is given to the hospital when you identify and certify that when the donor has been certified in a ICU. Then you wait for the response from the hospital whether they're willing to take the organ. And then the second intimation is sent. And at that time, blood can be sent for cross-match. Then wait for from the hospital or the cross-match result. And then the third intimation can be given regarding surgical, when the organ is being retrieved. When the organ is being offered to another hospital, what information will be required? You need to have this information to be passed on: the age and the gender of the donor, the date of admission, short history, if any comorbid factors are there, cause of brain death, very important, time of brain death certification, how stable they were hemodynamically, what is the blood group, what's the virology status, any infection, what inotropes you use to keep the blood pressure, the hemoglobin, electrolytes, sodium, liver function test, sugar. If you're offering kidney, then especially the creatinine is very important at the time of admission, at the time of offer, meaning that 2 or 3, 4 hours before the organ was removed, the output of urine, the hemodynamic status, and the ultrasound if possible during the bedside. If liver is offered, similar information, the liver function test needs to be, told about. Electrolytes like sodium. If sodium is more than 160, then or 155 in some case, the liver may not be, they may not take it. The bun and the creatinine, if the liver is fatty, the donor surgeon, what they have assessed, then there may be a biopsy required of the liver. And then bedside ultrasound is very important when they do a liver retrieval. We need to have a standard form for organ retrieval. I don't know whether Noto has the standard form, which should be downloadable, which all units should fill when they're sharing an organ with another center. And that form should have, as I said, all the donor details, their virology, their status, which I showed you in the earlier form, which side the kidney is, if kidney is being sent, the dimension, the weight of the kidney, number of vessels, approximate warm ischemia, time of retrieval, and separately pack the lymph nodes and the spleen. And then you take 2 vials of blood, to be sent, which you require for cross-match. And then you need to do documents for transport. You need to put 2 sets of documents which should be prepared. And it should cover should send human kidney or liver for transplantation, so that even if it is stopped by the police, they know what it has. the exact address of the hospital which received the organ, place of delivery, contact of 2 persons in the hospital, to whom concerned letter should be there saying what is the packaging in the organ, origin and end destination, so that if the police stops them on transit, this letter will help. And then, as I said, 2 names of contact numbers of retrieval and recipient teams, all this should be there. So there was a situation where there was blood was sent and the cross match was positive on 2 recipients and no blood was left. So we couldn't do any more cross match. And this way, we have had 4 kidneys which were wasted in our program in Chennai long time back when we started the program. So then we learned how to avoid such situations. So the recipient hospitals should keep enough blood separately in the fridge, which we should not send, just in case, the blood for cross match is required. And that's why harvesting the spleen and lymph node becomes very invaluable, because you can take the lymphocytes for cross match from the spleen and lymph nodes and then use it for cross match as well. How to minimize cold ischemia? You should ensure that, blood samples are sent in advance as soon as the organs are located, not when the organs are being retrieved, so that, the recipient is ready when the donor is surgery is happening. Also remember that for cross match, the blood sample may be different in each hospital. And this we did a review in Chennai of all the hospitals we are doing transplant. And if you see in this, some wants heparin blood, some wants, no heparin. Some people want it in EDTA tube. So it all depends which hospital is doing what kind of cross match. So this also is a variable practice. The cost of donor maintenance and surgery is borne usually by the state authority which is running the program. In Tamil Nadu, we used to have a reimbursement to donor hospital of rupees 75,000. I think in Maharashtra they have their own system and Karnataka has their own system. We do have Masterclass for organ retrieval for surgeons, which we have done successfully with Oxford Group. We are trained close to 250 odd surgeons. Under these are some of the surgeons trained in the organ retrieval at a Masterclass, which we conduct with Dr. Sonal Asthana in Bangalore at MS Ramaiah Medical College. And this is one surgeon who was trained with us a heart transplant surgeon who had never seen a heart transplant, from Madurai Government College. And he came to our training workshop and learned how to do heart retrieval and transplant, and went back and did heart transplant. These are some of our online courses which we run. In this, we also have a retrieval course which we are going to design. And if anybody is interested, they can use this QR code and go to the site. So this is thank you. This is my team of the foundation. They really do all the hard work. I hope that my talk was useful, and I'm sorry for a little bit of confusion with the, videos.
It's absolutely fine. We'll take it to Dr. Arvind and then we will have the questions afterwards.
I hope I didn't overshoot too much.
No, you stuck to your half an hour. Absolutely fine.
Supposed to be there only for 20 minutes.
It's okay. Dr. Arvind, over to you.
Okay. Dr. Shroff, Dr. Satya Sharma, Pallavi ji, friends, ladies and gentlemen, a very warm good evening to all of you. And thank you so much to the Mohan Foundation for this opportunity to share the information with people involved in the transplant process from across the country. I again would like to thank Dr. Shroff for sharing so much of data in the short time, because that's made my job easier. We did talk to each other about who's presenting what, but then we decided that we'll keep our slides as we have made. So there will be many slides which will be repetition of what Dr. Shroff has said. I'll skip those quickly and focus on what is new in my presentation. But actually, before I would go to the retrieval process, I would spend about 5 to 6 minutes, with the permission of all the officials of Mohan Foundation to discuss some very not so commonly known aspects of the organ transplantation scenario in our country. So what is the status of organ donation? The value of ischemia time, pre-op planning, intra-op steps, packing, preservation, transport, and the post-op. Now, this is again a very important slide. I would like you to focus on the lower slide. It shows how many organs we need in our country and what is the availability. So if you see, we need 200,000 kidneys, 50,000 hearts, 50,000 livers, again, thousands and thousands of lungs, but you see the number of organs which are available. So India's organ donation rate is one of the lowest in the world. In 2017, a mere 0.009% of all those who died and could have donated their organs. And if you look at the figures, 0.86 per million in India compared to 31.96 per million in US and around 47 per million. So summary, we have huge number of potential recipients. We have very few donors, which means a large number of people die every year for want of these organs. Again, a repetition, 8 lives and many more tissues. This is the act which made this possible. And I always show this slide of my teacher, Professor Venugopal, because it was his effort at doing the first heart transplant in the country, which actually brought the focus to the field of transplantation and added that required glamour to the field, which has so many people today. An important slide, total number of transplants in the country in 2022, 16,000, which means a good number of transplants are being done. But again, a very slide which conveys a not so happy scenario that out of 16,000 transplants, if you see total living donor transplants, nearly 90% of them, and deceased donor transplants about 10%, which means we do have a huge amount of transplant activity happening in the country, but majority of that activity, which is confined to kidney and liver, is confined to living related donor transplant rather than deceased transplant. If you see, number of deceased donors is still extremely low, only 0.009% of the total people dying. This is again an important slide which compares, don't look at these graphs, look at the bottom part, 2016 on the left side and 2022 on the right side. Total deceased donors 930 in 2016, total deceased donors in 22 941, not a great increase. Total deceased transplants 2265, but here it is 2694. What does it convey? That today we are harvesting, or we are able to harvest more organs per donor, deceased donor. So if you see, average transplant per donor 2.4, which has now gone up to 2.8. Now, this is the good news. We always give sad news. We must share the good news also. So good news is that there are more organs per donor being harvested today. Same thing, living donor, whether it is kidney or liver, in both these organs, 90% of the activity is live related and very few. This is one organ where there cannot be any live related activity. We do give hearts to various people, but in real life, we cannot give hearts. So this would be confined to deceased donors only. In lung, a lot of people ask this question to me that we have 2 kidneys. One can give 1 kidney and donor has no issue, and one kidney is enough for the recipient. So we have 90% of the kidney transplant activity being live-related donor kidney transplant. We have a big liver. About 70% of the volume of a liver a donor can give to recipients, which is enough for him. Donor regenerates his liver, so his life is not affected. So there is a lot of life-related activity. We have 2 lungs. So why there is no life-related activity in the lung? So the friends, the answer, this is a very important question, and the answer lies in the fact that when you give a kidney, the donor's life is not affected. In fact, there is some data to say that those who have donated kidney live slightly longer than average population. It's not that donation adds something or God gives you extra years. It's just that in the process of becoming a donor, they undergo so many tests that if they have any disease, it gets detected and treated, and therefore their survival is slightly better than the average population. Unlike that, when you donate a lung, your life is reduced by 10 to 15 years. And hence, donating lung cannot be permitted, because the first premise of a life-related donation is that the donor's life should not be affected. You can donate a lobe without affecting a donor's life, but the lobe is not adequate for the recipient. You cannot survive with just one lobe. But what can be done is 2 donors give a lobe each. And so therefore, 2 donors give a lobe each, so their life is not affected. Recipient gets 2 lobes. Now, 2 lobes are equal to 1 lung. So he gets 1 lung, and therefore it will suffice for him. Now, this is possible. However, it means that to save 1 life of a recipient, 2 people have to undergo surgery and donate lungs. Now, this is ethical issue. Is it right to subject 2 people to a donor surgery to save 1 life? So in whole world, there is just 1 center at Kyoto University in Japan, which we visited a couple of months back, where live-related lobar lung transplant activity is done. Nowhere. In our country, all the centers involved in lung transplant do deceased organ donation only. There is a lot of division amongst countries. So if you see, the donation in Telangana is much more. Tamil Nadu, Karnataka, of course, is there. Gujarat and Maharashtra are catching up very fast. These are top 5 states in terms of the volume of donation. This is an important piece of advice for a piece of information for you. And I would show you, So this is oftentimes people talk of north-south divide in our country. And I think there is nothing else that I'm aware of. There is such a contrasting north-south divide as in terms of organ donation activity. So green area reflects the places where the organ transplant activity has been initiated, expanded, well established. So you see Gujarat, Maharashtra, Karnataka, Telangana, Andhra, Tamil Nadu, Kerala, the entire south organ donation activity is initiated, well established, well expanded. White are areas where it's been initiated but not well established and not well expanded, which includes most of central India, Rajasthan and Madhya Pradesh, and a lot of north. And when you go up and you go to the northeast, it is not even initiated. So if you put not initiated and initiated but not expanded, you cover the whole of north and eastern India. So there is a huge north-south divide. So there is a message for all of you coordinators that particularly in our northern part, there is a need for a lot of public awareness to increase. This was the situation in South also 15, 20 years back, but they did a lot of work in raising public awareness, which has led to the results today. So I think we need to do the same here also. So with that, some slides about the general aspects, I come to the core topic of the explantation. Now, Dr. Shroff has already introduced this concept of ischemia time. So as he showed, there are two types of ischemia. Means there is no blood supply to the tissues. So there is a warm ischemia, which means that body is warm and the organ is without blood supply, but at normal body temperature. And this happens twice, as he showed. First is when we are taking the organs at the time of donation, from the time the heart stops or you clamp the aorta, which I'll discuss, to the time you start perfusion of a cold fluid into the artery of that organ. So that few minutes is the warm ischemia time 1. And the second time a warm ischemia takes place is when you take out the organ from your ice box, you put it in the body and you start to join the artery, vein and the third structure. Before the perfusion starts again, this is warm ischemia time 2. And the cold ischemia time, and this is the maximum functional warm ischemia time. For kidneys, 2 hours, for liver, half an hour, for lung, 1 hour, for pancreas, 30 minutes. So you can see if by any chance the organs have longer warm ischemia, the organs get necrosed and there is serious problem. And cold ischemia is the time from the start of the cold perfusion till the initiation of reperfusion in the recipients. And this varies. Unfortunately, our thoracic organs have least ischemia time, about 6 to 8 hours average. Intestines have longer. Liver gives you longer time, pancreas still longer, and kidneys give you the longest organ preservation or cold ischemia time. The major challenge before us today is to prolong this ischemia time, because in a huge country like India, if you have to shift the organs from one corner to the other using the regular aircrafts and not your private aircraft, which is impossible in our country, we need to do something to increase the cold ischemia time. Now, coming to the process of organ donation. So this is a typical WhatsApp information you get when you have a prospective recipient. You will have the name, the center, the age, the sex, the blood group, MLC or non-MLC, diagnosis, date of incident, date of admission, patient on ventilator, first apnea test, second apnea test, tentative retrieval time, who's given the consent, COVID, height, weight, inotropes, and the contact details, and which all organs have been alerted. Usually, you're also supplied the chest X-ray, and we oftentimes request for a CT scan when we go for lung retrieval. Before claiming, you need to check the age of the patient, the blood group. In lung, size matching is very important because you have to put that lung in the chest cavity. And if there is a huge size mismatch, which means the donor is large and the recipient is small, or vice versa, then there will be problems. So we do a side meshing also. For us, it's important that the size is about 20%. So what we do, we calculate the total lung capacity of the donor, so of the recipient, and we try and do about plus minus 20%. That we can adjust. If the mismatch is more than 20%, then usually it becomes difficult. So 80% to 120% is the allowed range. We unfortunately have mostly the restrictive variety, which is interstitial lung disease, where the lungs become very small, the recipient chest cavity becomes very small. So we need smaller size lungs. And unlike Western countries where COPD is the commonest cause for lung transplant, where the chest is large, barrel size, where a larger size lung is preferable option. Now, when you claim for the organ, your retrieval team will go, which will have surgeon, coordinator, technician. You would be carrying your equipment. You have to take care of your logistics. When we go to Western countries, we find that people are flying in the chartered aircraft or helicopters. That's a rarity in our country. And we have to manage with the standard flights, which oftentimes becomes a real logistical challenge. There has to be a management of the donor at the donor hospital, and you also have to take care of the logistics journey. Now, in the process of organ donation, I would focus and give you some tips what you do before the donor goes to OT, what you do in the OT, and after the OT. Now, before the donor goes to OT, one of the important aspects, which is not given so much importance to coordinators in India, but coordinators play a major role. And I would request all of you coordinators to get involved in this activity, is what we call donor optimization. I was discussing with Dr. Shroff yesterday, and he said that in our country, somehow, because of the attitudinal issues with the ICU people, coordinators are not involved in the process, but in Western countries they are. And I would say that donor optimization is something. You guys do a lot of work on logistics end, but you should also get involved. Now, these people will have severe brain injury. They have neurogenic pulmonary edema. They have brainstem death. So they have a high risk of aspiration, infection, and injury because of the mechanical ventilation. So I can't go into details, but 5 important tips I would give you. You should focus on what is called protective ventilation. Now, I would encourage all of you coordinators to talk to your ICU people in a friendly manner. Sir, please, we want to know. Yesterday we've heard this term protective ventilation. Could you please tell us what it means? It basically means giving ventilation with the least possible tidal volume and using the lowest pressures, so that the ventilation associated injury to the lungs can be avoided. Very important for us. For lung aspiration, as I said, is an important problem in these brain dead patients because they are unconscious, and therefore a special attention has to be paid. They usually have hypotension, and the tendency in hypotension is to give them tons and tons of fluids, which makes them overloaded, which actually overloads the lungs with fluid. They have pulmonary edema, which makes our lungs unusable. So we need to use vasopressors to maintain the blood pressure so that the urine output is maintained. Kidney is not damaged, but at the same time, lungs are not destroyed. We always do a bronchoscopy to see that everything is good. And as I said, these people need steroids. So process in donor hospital, you cross-check the donor details. We go and do a bronchoscopy. We get a bulk sample. And now you are moving into the theater. So the donor has been moved into the OR now. Now, this is how you will never have more chaotic scene in any OR than in the organ donation process. Normally 3 to 4 teams have come. Each team has 4 to 5 people. Each is bothered only about taking his or her organ at the quickest and rushing out. They are not concerned with other people, and oftentimes it's a chaotic situation. As the coordinator at the donor hospital, I think it's your responsibility to very humbly request everyone and maintain sense, maintain discipline in the OR. We always start, whenever I am there, I always, before you start the incision, I request everyone to stay still for 1 minute and pray for the peace to the departed soul. It's a very noble work which this donor has done. And I think I would request all of you, next time you are in the OR, just shout loudly, request everyone, please, we have to pray for 1 minute for the donor. Ask everybody to stand still, no discussion. Only the anesthetist continues to ventilate the patient. Stand still for 1 minute and pray for the peace to the departed soul. Request everyone to respect asepsis. People will be in a hurry to just take their organ, and I've seen those people who come extra touching the trolleys. And also your roles, donor hospital coordinators, I'm addressing all of you. Your role is to look around and see that asepsis is not thrown to the winds. You have to ensure that the samples are collected, the paperwork is done, which Dr. Shroff has so elegantly described, and of course, make arrangements for all the teams to depart. We of course, when we do lung transplant, we have some specific instructions to be given, which we share with the with the donor organs. We try to collect all the information. So we have a Google form which our coordinator fills there only on site, where we collect every possible data. Now, start of the procedure, as Dr. Shroff showed, let's say we are doing a multi-organ. So there is heart is going somewhere, lung is going somewhere, liver is going, 2 kidneys are going, intestines are going, pancreas are going, all organs are being taken. The chest incision and the abdomen incision start simultaneously. Typically, we'll have 2 teams assisting. So thoracic team, if it's a heart and lung going to the same hospital, there will be 1 team. If they are going to different hospital, there will be 1 or 2 members from the heart team, 1 or 2 members from the lung team who will scrub, and there will be an abdominal team which will start. So we usually start with long incision. In the chest, we open, as he showed, by using sternal saw. You go inside, you open the pericardium, and then the cardiac team inspects the heart. This is all done by the cardiac surgeons. You isolate the aorta, the SVC, the IVC, the pulmonary artery, etc., etc. When lung, now after, so they check their organ and they say, yes, heart looks all right, we are taking it. Then they move aside. The lung team opens the pleura on either side, and we do 3 things. Number 1, we palpate the lungs to see if there are any nodules. Sometimes there could be undiagnosed tumors there. We see if there is any hematoma or injury or laceration to the lung. We also see if there is any blood or fluid in the chest. And we also see if there are any atelectatic areas. And if so, we ask the anesthetist to bag a little harder and see that all the parts of the lung are well expanded. This process is called recruitment. And we do it for 5 minutes. We give 100% oxygen, and then we ensure and do the blood gas to see whether the lungs will be accepted or not. This is how we decide on the lungs. Now, after that, we need to do, before the heart is stopped by clamping the aorta, each person has to infuse a cold solution into the artery of his organ. This is common to all organs. So whether heart, lung, liver, kidney, pancreas, intestine, the artery feeding to that organ has to be cannulated, and a cold solution, a fixed amount, has to go into that organ to perfuse. Why do we do that? Two reasons. One, it is at 4 degrees centigrade, so it cools the organ completely, totally from inside. That's number 1. So cold ischemia, hot, warm ischemia time is now converted into cold ischemia time, thereby prolonging the ischemia time. And number 2, this solution is a nutrient solution which will supply the cells of that organ during the time that the organ is in the storage solution. So different solutions. For heart, there is a custodial solution. For lungs, we use Perfadex solution. For liver, they use University of Wisconsin solution, and also same solution for the kidneys. So abdominal organs, they have University of Wisconsin solution. We use Perfadex for the lungs and the heart people. Now, this is based on the metabolism of each of these organs. So the composition of these fluids varies slightly. Now, the upper part of the slide shows which are the structures. So first, we cannulate. Suppose there is a heart team, they'll cannulate the aorta. We will cannulate the pulmonary artery. The liver team will cannulate the hepatic artery. They will also cannulate the aorta in the area of the 2 renal arteries. And all these cannulae will be placed before the heart is allowed to stop or the aorta is clamped. So before you stop the blood supply, you have all these cannulae ready. So that's number 1. There has to be a lot of coordination between. You can't say heart and lung are ready, they clamp the aorta, and liver was not ready, and liver becomes, their ischemia time is, warm ischemia time is increased. So we have to talk to each other, and only when everybody says, okay, we are ready, we are ready, we are ready, then you give 25,000 units of heparin, because this prevents any clotting in the organ after the blood circulation is stopped. We also give something called prostaglandin for our lungs. And then we say, if the chest is also being used. We say, okay, cross clamp. What does cross clamp aorta means? Aorta, when it starts from the heart, you clamp the aorta there, which means all the blood supply to all the organs is now stopped, and people can start infusing their solution. So the moment we cross clamp the aorta, if the chest organs are not being taken, only abdominal organs are taken, then the abdominal surgeon will cross clamp the aorta below the diaphragm. So you cross clamp the aorta, the warm ischemia time is now converted to, or rather, and start the infusion. So you have now cold fluid running into the artery, into the organ. Heart will have their heart fluid going, lung will have their lung fluid going, liver will have the liver fluid going, and so also the kidney. So the different amounts are used. This allows the nutrient to go to the organ. This allows the temperature of the organ to be brought down. And these solutions, we need not go into details. They are different type, but they are meant to give the nutrition to the organ. So cross clamping of the aorta is what interrupts the blood supply. And after that, once the perfusion is finished, you take out the clamp and then you start mobilizing the organs. As Dr. Shroff said, heart is the first to be taken. So they take the heart and then put it in the solution and then they go away. Then we come into picture, we take out the lungs. Both lungs are taken as a common block. And then we pack it, and the separating into two separate lungs we do back in our OR. Side by side, the liver team is working in the abdomen. Usually kidneys are harvested by the liver team only. Now these are different diagrams to show how each of the organs. But I would just show that in heart, when you cut the SVC, you cut the IVC, you cut the aorta, you cut the main pulmonary artery and the left atrium. So when you take this heart and you go back to the recipient, these 5 structures need to be joined. Coming to lungs, we cut the pulmonary artery is cut, main pulmonary artery, and then when we will separate the lungs, we'll separate them into right and left. The pulmonary veins, there are 2 on either side. If you cut the veins, you will have to do 2 separate venous anastomosis. So instead of that, we take a cuff of left atrium. It's called the LA cuff. So that 2 veins join together. So with the cuff, when we take, instead of joining 2 veins, we have to join just 1 cuff. So that saves 1 anastomosis. So when we do lungs, we do pulmonary, sabse pehle we do main bronchus anastomosis and then pulmonary artery and then LA cuff. So 1, 2, 3, 4, 5 anastomosis in the heart, 1, 2, 3 in the lungs, but into 2, 6 anastomosis for the bilateral lung transplant. In the liver, you join the hepatic artery, the portal vein, the CBD, and the hepatic veins of the IVC. So 4 anastomosis. And in the kidney, it's the artery, vein, and ureter. So 3 here, but kidney is only 1. So there'll be 3 anastomosis, 4 in the liver, 3 into 2, 6 anastomosis in the lungs, and 5 in the heart. This is what will be done at the recipient hospital. So these are, now after once you take out the organ comes the packing. What is the need for packing? Why can't we just take it out and put it in the ice bag? Because number 1, you don't want and you cannot allow the organ to come in contact with the ice directly. Never, never do that. 1. 2, it has to be stored in an absolutely sterile environment. So therefore, we use a 3-bag method. The first bag is filled with preservative solution. So we use Perfadex. So we have Perfadex at 4 degrees centigrade, which is put into that bag. No ice. I repeat, no ice, only cold Perfadex, and you put the organ into it and remove all the air and close it tightly. You put this first bag into a second bag, into which also small quantity of cold saline. Again, no ice, no preservative solution, because this preservative solution is not needed now. You only need cold temperature. So we take cold saline and you put into that second bag, and this second bag is now put into the third bag just as an added safety measure, which is then put in the ice in the cold in your carry bag. So this is how you do it. You do a triple packing and then you put it in the ice box. Right. So conventional storage is done at 0 to 4 degrees centigrade, but there is data now coming from Toronto General Hospital where we visited, which said that if you do storage at 8 to 10 degree instead of 4 degree, the lungs can be lasting up to 16 to 18 hours instead of the 6 to 8 hours. Now, this is a very path-breaking study they have done, and they now use this special fridge, which we also have acquired in Medanta, which we are using. It's got some special pads inside, which allow the temperature to be maintained between 8 to 10 degrees Celsius, which they have done studies and shown is better than using it at 4. Another few slides. Pallavi ji, can I take few more minutes?
Oh, Dr. Arvind. Yeah, we have time. Yeah.
Okay. Another term the coordinators will hear often is something called ex vivo perfusion or organ care system. So when you take out an organ and put it in the ice, this is a form of static cold storage. Now, there is no movement, no perfusion happening. You perfuse the organ with cold solution, and now you have put it in this thing, and you forget for next 6 to 8 hours. So people thought that instead of that, if we perfuse the organ, continue to perfuse it with the cold solution and also give some other. For example, lungs get air as well as blood. So if we cannulate the trachea and connect it to ventilator and gently ventilate these lungs with oxygen and continue to run the fluid through the pulmonary artery and drain it through the vein, this is called normothermic preservation after the prior cold perfusion. This has been shown to enhance the preservation, and therefore more and more centers are resorting to it. Another thing is called organ care system, which is being used especially in heart, where you actually cannulate these structures and you have this heart continuously being perfused in this specialized machine while you are transporting it from the donor hospital to the recipient hospital. So this is called organ care system, very expensive system available and being used in some countries abroad for heart. There is a dedicated system for the lungs where you have the organ working. So as opposed to static storage, this is a dynamic storage where there is a continuous supply going to that structure. Similar thing is now being developed for kidneys and for liver also. However, these are latest developments, very expensive, not yet in common use in our country. Now, this was about the process of organ harvest from the donor. Now, everybody takes his organ and just packs it and runs away from the OT. The cardiac surgeons have run away with the heart. The lung surgeons have run away with the lungs. The liver surgeon has run away with the livers. The kidney guy has run away with the kidneys, the pancreas, the intestines. What is left in the theater is a dead body of a noble individual whose family agreed to donate the organs, and they have agreed to save lives of 7 to 8 people. So, dear coordinators, this is the time where you again play a huge, noble, humane role in ensuring that the body of this noble soul is packed in a respectable manner, delivered to the patient's relatives in the most humane, respectable manners befitting the noble deed, and in case there are any medical retirements, these are also addressed. With that, I come to my last slide, that organ donation in India, at least deceased organ donation, is still in its infancy. Numbers are very small. Opportunities are huge. 0.009% of all deaths being utilized. And I think all of you guys, transplant coordinators and noble organizations like Mohan Foundation and the people who are the backbone in the process of organ donation have a huge role to play in spreading this information amongst the people so that more and more of the waiting recipients who are dying today can be offered organs tomorrow, giving them a gift of life. Thank you very much once again to Mohan Foundation and to all of you, ladies and gentlemen. Thanks again.
So much, Dr. Arvind. That was an excellent, excellent presentation, and we can have both. So before we take questions from everyone else, I have a question to ask. Thank you for bringing focus on the fact that this is not just a dead body, but it is a donor, and there's respect and integrity to that so-called body. Thank you for bringing back that focus again and again. You said that there is quite a lot of chaos and mayhem in the operating theater. There are different teams trying to retrieve organs. So who is really coordinating? Is there a conductor of sorts who really decides what is going to be happening, or is it free for all? I mean, for people who've not been in the OT at a time like this, I'm keen to understand that.
Should I answer? Dr. Shroff, you want to take that?
No, go ahead. Answer.
Okay. So, Pallavi, how I would look at it is that, see, heart people will come, lung will come, liver will come. I think there has to be somebody from the donor hospital, a doctor, because if the coordinator was to tell those big ego doctors who have come, sir, please don't make noise, I think there will be more noise in the theater. So I think some doctor. So if there was a donation happening in my hospital and I'm there as a lung retrieval surgeon, I would take the lead and I would say, well, friends, all of you are welcome. However, we have to have some sense, some discipline in the OR. And I've done it, not only in my theater, I have done it in different hospitals. I would raise my hand. I said, friends, we are in the OR, not in the market. Please, I would start asking people, okay, who are you? Heart transplant surgeon. Okay, sir, who's your assistant surgeon? Who's your coordinator? All other people, please move back. Please move back. I think if out of all the people present, if one person takes a leadership role, and if you start doing it very with passion,
certain
authority,
degree,
I think people will listen. Nobody
Dr.
objects.
Arvind, you would move away after your lungs are retrieved. Then who manages the rest of the?
So therefore, once I move away, the next team, somebody has to continue what I have initiated. So as long as I'm there, I ensure that there is no chaos there. For me, I think the first casualty that I see happening, Pallavi, is asepsis. People are there, they're touching the trolley here, there, everywhere. And it hurts me that the asepsis is being thrown to winds. I'm wedded to asepsis and I ensure that asepsis is respected. So I think after one shouter has left, it is for the next team, somebody else to take care, and then somebody else, and then some. And when everybody else has left, then it's the coordinator of the donor hospital who has to ensure that this noble deed of the donor is respected and he is given a decent, respectful departure from the OR and from the hospital.
All right, Ganesh, are they allowed to unmute themselves? Dr. Shah, you were saying something?
So I think, this is a very important point, and you need to have a central conductor. And as, Dr. Arvind said, that, the key here is I have had situations where everybody is left and there is nobody in theater to even close the body. And that becomes really very sad.
Yeah.
It is usually the donor hospital which actually takes the brunt. Most of the times is when you see the theater after the multi-organ retrieval has taken place, it's a huge mess. Many times, unfortunately. I mean, one of the problems also happens that, many times they have a flight to catch, some of them, so they are in rush. And
not just apathy, it's also,
and the ischemia time is such that they don't want to waste any time staying back. So, there needs to be a plan of action before, when you have multi-organ retrieval, who's going to do what. And that's where, the donor coordinator plays a big role. Sometimes when the donor coordinator is a very junior person, nobody listens to them, unfortunately. But I think, the donor hospital surgeon has to be there. And this again comes to, when we have a non-transplant organ retrieval center, what will happen there? That's what worries me sometimes. And there it is going to be more chaotic. So the responsibility again has to be with somebody who is an authority, and then, and somebody from the donor hospital to take charge. That, till the end, till the body is closed, cleaned. After closure, also the body needs to be washed or cleaned in theater, because there's so much blood stain somewhere sometimes, So that needs to,
Yeah.
body needs to be clean, and then body needs to be packed around a nice clean sheet. Sometimes a clean sheet is not available, and Letta has had the experience when they had to run to get a clean white sheet to wrap up the body. So in one foundation, what we did was we bought 10 sheets in the program and kept it as spare. If there was such a situation, that sheet would come out to be used for the donor. So these things need to be planned in advance, really. If you really want to, keep the program clean and be respectful of the donor, you need to plan these things ahead. And of course, we need to do prayer before and even towards the end, and send off the donor to the family. And prayer in the end is happening more and more and more and more hospitals. I'm very happy,
Yes.
especially it started
Donor walks and everything.
Rajasthan. Public also comes forward. So that is all very nice. And that's very, very important, again, to be very respectful. But many of the mature programs now have got a system going. It is only when you initially start a program, you face this difficulty. But once you've gone through the whole process and sorted it all, then you are okay.
All right, so there is a question here that is there any strict rule that kidneys to be harvested before liver? As I've seen in some cases that kidneys are being harvested before liver. Please guide.
This is happening in one place in particular, I think it is in Nagpur probably. Normally it is not done. The liver has to go before kidney. What happens is, unfortunately, let me be again get honest here. Sometimes the liver surgeon is somebody who is a little new and takes a lot of time to retrieve the liver, as a result of which the kidney suffers ischemia time. You must remember that the maximum number of utilization of organs in any program anywhere in the world in solid organs is going to be kidneys. And most of the transplant programs in the world develop after the kidney program has taken off. So, you piggyback on the kidney program. So you cannot have a situation where you take the kidneys out and transplant and they don't work in the recipient. If the ischemia time is long, especially the warm ischemia, if the liver surgeon takes a long time, then the kidney can suffer. And then it can happen that the kidney will not work. And that may be the apprehension of the surgeon concerned. But this again is a teamwork. Remember, this is a team effort. It's a teamwork. So the liver people have to be more cognizant of the fact that, they can't take undue long time. They must make sure if they're taking longer time, the kidney is kept cold, more ice is packed around the kidney, the perfusion keeps going. It's so important that you cannot, damage another organ, compromise the situation. And that's why I think in one program particularly, that surgeon may have had that experience and, they remove the kidney before liver, but that's never done anywhere else in the world.
Thank you, Dr. Anybody else has questions? And if you're I don't know, sir, Ganesh, I would like them to be allowed to unmute themselves if they can.
Yes, ma'am, I have
Any
updated. They can do it.
You can. Okay. Anybody has a question that they want to ask, either Dr. Shroff or Dr. Arvind?
Ma'am, I have a question.
Yeah, sure.
Yeah. Is it possible to include organ transplant subject in medical studies, like to have that awareness in a faster way through medical professionals in the society? Because as sir said, the India percentage is 0.09. That is very low.
Yeah, 0.06.
So the actual donation rate is 0.7 or 8 now. And I think, this is another discussion point, not related to the current subject. So I would not go into any great detail, but there are, discussions regarding this to include part of organ donation in this curriculum. In fact, not too long back, even when we had a meeting with Noto, this suggestion was made. And remember, this is an evolving area in the sense that the guidelines and the practice, everything is changing as we go forward. If you remember 10 years back, we only did 200 to 300 donations. And last year we did 1,068 donations. So we are progressing slowly, and it will take a little bit of time for these things to come into the mainstream, into the curriculum, but it will happen.
Thank you, sir. Thank you very much.
Dr. Satya, you had a question?
No, no, Pallavi, I had a comment to make from, pardon me, from Commonwealth Tribute to Life point of view. I must say that this was very useful, and it should be used for informing other countries which are in Commonwealth Tribute to Life project. One small little variation can be done in due course, which is by the person who starts or the chairs, for example, yourself. You can say that these are the most relevant parts in India, and of course there might be minor modifications possible in other countries. This is a given. It's understandable. Most people would appreciate that, but just one comment like that might be useful for the chairman to say in the beginning. Thank you. But I found it very helpful, very useful, and I think Commonwealth Tribute to Life would should disseminate this sort of masterclass not only to the Asia, but even to the other countries, whoever can log in. So I'll get in touch with my office and sort this out in due course. Yeah.
Thank you. Dr. Arvind, you wanted to say something?
Yeah, I just wanted to add to what the question was about inclusion of this topic in the MBB. Of course, it's a desirable objective that it should be included. But, that will only sensitize a very small percentage of the people. And many of them have this sensitization even today. What is needed is to increase the awareness amongst the masses and to remove the lot of religious taboos which are associated with organ donation. A lot of people feel that if you leave some organs here, your body will be incomplete, and when you go, your soul may be hanging around here. So I think our religious leaders have a huge responsibility and role to play. And in India, we have, I don't want to name them, but we have some top 5-6 organizations who have following in millions. And I reckon a situation where all these leaders, 1, 2, 3, 4, 5, 6, some top 6, 7 religious organizations across various religions issue not a fatwa, but issue an advisory or a request to their followers that this is a noble deed and this organization recommends. I think that will be the turning point.
Thank you so much. Any other questions from the audience?
Pallavi, I was the one who asked if the lymph node, why take lymph nodes?
Yes.
If either Dr. Shroff or Dr. Arvind can respond to that.
It is, because the lymphocytes in the lymph nodes are very recent ones, and the cross match which you do with those lymphocytes are very valuable, especially for kidney. But cross match is very valuable and very much required in kidney and to some extent liver. Heart probably don't do cross match anymore. Some of them would do, but they're not very bothered. I'm not too sure about lungs. I don't think so. They also do any much bother about the cross match. They will look at the blood group and they'll go forward. But cross match is very important for the kidney guys because of the rejection. When it happens, then you lose the kidney many times if the rejection is really what is called hyperacute rejection. And that's why sometimes, at least when I worked in England, they use the lymphocytes taken out from the spleen and the lymph nodes to do the cross match and further studies. Whereas in India, when I came, I found that they would take the lymphocytes from the blood. So I also showed you the situation where we had to waste the kidneys kidneys in our program because we didn't have enough blood for the cross match. And lymphocytes and removal of lymph node and spleen is not a common practice in India. So I think it is very valuable resource to take out the lymphocytes. That's why I think taking the lymph nodes and spleen is very valuable. It's a good practice.
Any other questions from the audience?
Do you do cross match, Dr. Arvind?
We do, but
historical.
Yeah.
Ma'am, I have one question.
Yeah, Preeti.
Ma'am, like Dr. Arvind Kumar said that all the surgeons comes and take the organs. So basically, I want to understand. So who is the doctor? Like who is the surgeon who is supposed to close the body of the patient?
Good question. Yeah.
That's why I said to you that the donor hospital in the end has to take the responsibility of closure, cleaning, and wrapping up the body respectfully. So it is usually in the end the kidney people who are the last people to go out, and the donor hospital which will take the responsibility.
Okay, sir.
Thank you so much, Dr. Shroff, Dr. Arvind. Very wonderful, informative talks by both of you. Thank you so much for having taken the time to be with us and by enlightening our coordinators. And thank you all the coordinators for attending to more such sessions. Thank you so much.
Thank you. And all of you have a wonderful evening.
Thank you so
You-
much.
Thank you, sir. Thank you, ma'am.
Thank you.
Thanks, Preeti.